Coming up, prescription painkillers, use and abuse. Insights on PBS Hawaii is next. Aloha and welcome to Insights on PBS Hawaii. I'm Daryl Huff from Hawaii News Now. Across the country, deaths by overdose of prescription painkillers, mostly containing highly addictive opioids, have reached epidemic proportions. From 2000 to 2014, the rate of opioid-related deaths nationwide increased 200%. And in Hawaii, an average nearly 50 people die each year from abusing these medications. Are doctors overprescribing? And what's the patient's role when it comes to managing medications? Coming up, we'll discuss the problem and explore possible solutions. We'd like to hear from you during our show, so call us at 462-5000 if you're on Oahu, or 800-238-4847 if you're calling from a neighbor island. You can also watch Insights streamed live at pbshawaii.org. Just click on the title of tonight's show, or find us on Twitter at PBS Hawaii. Now to our guests for tonight's show. Dr. William Haining is a professor of psychiatry at the John A. Burns School of Medicine and specializes in addiction psychiatry. He's also the principal investigator for the Pacific Addiction Research Center. In 2014, the Hawaii Medical Association named him Hawaii's Physician of the Year. Dr. Carrie Taylor is a certified physician in physical medicine, rehabilitation, and pain medicine. Dr. Taylor helps patients identify the source of their pain and treats the whole patient using a biopsychosocial approach. Claire Santos has been a registered nurse and patient advocate in Hawaii for more than 30 years. Her perspective on the use of prescription painkillers changed when her older sister, Marcia, fell victim to the long-term abuse of these medications and died in 2014. And Jennifer Fisher is in recovery herself from addiction to prescription painkiller, OxyContin. Ms. Fisher first started using OxyContin after back surgery and was addicted to the medication for 5 years before seeking help. Let me start by throwing this out. I did a little research and I found this in my family medicine chest. Mm-hmm. It is a prescription for hydrocodone, acetaminophen, and it was prescribed after a teenager had wisdom teeth pulled. Mm-hmm. Dr. Haining, what jumps into your mind when you see a bottle like this? Should I be freaked out by this?
Well, that it's part of an enormously large family of similar bottles sitting in medicine cabinets all across Oahu. People don't throw away things that they pay money for, so they have a tendency to sit there until, I'm saying this half jokingly and half not so jokingly, somebody comes to a dinner at your place and decides to inventory your medication cabinet, at which point they will help relieve you of the contents.
In other words, having this around is an invitation to people to come and steal it.
Well, it's got significant value. We're not just talking about street value, but we're talking about normative value in terms of its meeting the needs of people who have an opioid dependence.
And Jennifer Fisher, you know, when you see this, this is what got you started, right? Something along these lines? And what's it like? How does that happen?
Well, you start out taking prescription medications that are given to you by doctors, prescribed for, I had back pain and ended up having a herniated disc. And so when the doctors, even though I told them I had an addictive personality, when they told me that it was okay to take, I was fine with that because I wanted to listen to my doctor. But what happened with me is that that drug turned a switch, and after 2 or 3 days, I not only needed it, I wanted it.
After 2 or 3 days?
Yeah. And so I continued to take it for, I think, up to a year. And then my doctor said, you need to go see someone else. I can't prescribe this for you anymore.
You were fighting with him over that?
Not really fighting with him. He knew that I had crossed the line. So he sent me to a psychiatrist and then to a pain management specialist. But that was after I had had surgery.
Well, we'll get into a little bit more about how you recovered. But Claire Santos, I'm so sad to hear about your sister. Our feelings are with you about that. But does this bring this back? Is this the kind of stuff that started her?
She started out with chronic pain. She was a waitress, and that's a very physical, brutal job, and had neck pain, neck surgery. Didn't help so much, and the pain pills followed, and the every 30-day prescription followed until she was addicted and ultimately overdosed.
How did that happen in terms of, it's a prescription drug, and so somebody theoretically is managing how much she's taking?
The physician was prescribing every 30 days. So when you discuss the ethical lines of pain management, you have some who work with the patient, the whole person, and some who simply write a prescription every 30 days. And my sister, unfortunately, fell into the hands of the less ethical type of practitioner.
Was it, and I apologize if this is too personal, but was it a matter of her deciding to take too much, or was it an accident?
Most patients start out following doctor's orders, as Jennifer said. This is what the doctor said to do. Take this every 4 hours, take this every 6 hours. There's not much of an individual approach to pain management. We have too few pain management centers. So the patient does what they're told, and they keep taking it, and then they start wanting it and then needing it, and you wind up in this mess.
Dr. Carrie Taylor, as a pain management specialist, what do you think a lot of people managing pain are doing wrong when it comes to these sorts of medications?
Well, I think over time, just like some of the other protocols for how we manage different medical conditions, I think over time it's changed, and we've realized, I would say over the last 10 to 15 years, that opioids have a very high risk factor, and there's a risk and a benefit and alternative to taking a lot of the different medications. I think there's a time and a place for an opioid depending on the medical condition and what is being treated. But there also has to be an entire treatment plan that goes along with it. What's happened over time, and you see a lot with the practice of medicine, like you said, for yourself with your sister, it takes a lot of time. If you're going to prescribe an opioid or anything for that matter, there has to be time with the patient. There has to be a patient-physician relationship. There has to be a lot of looking at the whole thing. What's going to happen if I do write this prescription? That goes for all different medical conditions. So I think over time, the standard of care now has shifted back, and people realize we have a problem here. And so what do we do? How do we solve this problem? And like a lot of different things in medicine, as you change the protocol, then you go, okay, what do we do now? And I think that's where we're at over the last, I would say, 5-7 years. And we just have the prescriptions. There's too many out there right now.
Dr. Hayden, what's your perspective on that?
You began a few moments ago in the lead-in to all of this by saying, is this a problem with the doctors prescribing too much, or is it a problem with patients abusing the drugs? I want to submit that there are a bunch of different streams that all feed into this one river. And it's going to be hard to spread apart the respective streams. But to give a frame of reference, both my dean and I went to medical school about the same time, close on 50 years ago. And I talked about this a little bit just an hour or so before I came in. Our memory together is, in fact, that around 1980, between articles in JAMA and New England Journal of Medicine, none of which were very good articles, by the way, the contention was made that pain was not being adequately treated in this country, and that people were being led to needlessly suffer as a result of untreated pain. And it began what ultimately turned into the Fifth Vital Sign initiative and a variety of other forceful efforts on the part of well-intentioned people to respond to a problem that may not really have existed. And in the case of the Fifth Vital Sign, which was seeing pain as a vital sign like blood pressure or pulse or temperature, respiratory rate, that's actually only within the past week been dismissed as an actual valid measurement, at least within the AMA. We'll see how it plays out with other organizations.
Let me ask you, Jennifer, do you blame your doctor for what happened to you?
No, not really, because I wasn't truthful to my doctor. Like I had said earlier, we were talking, and I manifested the pain because I was so addicted to the drugs. So the amount of medication that I was on, I shouldn't have been able to feel anything. And, I don't blame the doctors because there's just no value in that.
Claire Santos, your sister's story is tragic, of course. 50 deaths a year from this in Hawaii. It's hard to say small number or big number. Every one of those lives matters, of course. In her situation, what was the, do you think that she was an addictive person, or do you think that she really did just fall into this because the doctors were overprescribing?
To go with Dr. Haning's many streams fill this river or meet up with this river, she lived alone. She was a waitress without health insurance. She had little support. She was on charity care or disability. Did not have a whole lot of support or guidance. So my premise here is to come back to the front end of prescribing is what kind of education does the physician or the prescriber have? Because now we've got nurse practitioners, physician assistants, a lot of different people prescribing. What's their training to manage pain? Did he provide her the correct information she needed to decide to take that medication or not? And did you feel that you were given the proper education about taking pain pills? So many patients will go home and say, nobody told me I shouldn't drive when I take this, or no one told me I shouldn't sign a legal document or make major life decisions. There's a big gap in communication and education all the way around.
Let me ask Dr. Taylor, what should patients be asking about these drugs when they're being prescribed the first time?
I think they have to walk out of the doctor's office or wherever they're being prescribed and know fully what those medicines are. What's the risk, the benefit, the alternative? Why do I need this medicine? How does it work? What's the mechanism of action? What are the risks to it? How does it fit in with my treatment plan? These are the other medicines I'm on. These are the counters that I'm on.
Let me interrupt you. So when you talk about a treatment plan, is it by what point am I going to be done? That should be talked about at the beginning?
Definitely, definitely.
And
also, what else are you going to do besides this medicine?
You know, let me ask Dr. Haning this point, because I enjoyed your description of this when we were talking before the show. What is that mechanism? What is the thing about opioids that, one, I guess makes them work, but two, also makes them so potentially addictive?
My stars. Well, the pathways that this trips off are not merely analgesic, getting rid of pain, but also euphoric. The degree of reinforcement that people sustain as a result of taking that, it's not as if you're just getting rid of the pain. Please note that everything on television these days is oriented towards telling your doctor or asking your doctor, do I need such and such? Is such and such right for me? There doesn't seem to be a similar ploy for, is OxyContin right for me? What are the risks associated with that? Short of death, respiratory depression, loss of limb, pancreatitis.
Well, according to the current TV commercials, constipation is the worry with these medications.
Thank you, that'd be the major one.
That was very strange, that whole set of ads. I think they ran in the Super Bowl, and everybody's going, what is this about? It was opioid constipation.
It's on TV right today.
So is it such a big problem that it's the side effects of it that become another medical market?
And
That's what they
is
did.
now.
Yeah.
That's so strange. How big a problem would you folks say this is in terms of really, we talk about deaths, but I mean, there's a lot of people living with this.
I think we have to look at, as Dr. Taylor has said and Dr. Haning, what are we treating? For example, for 10 years I was a burn care nurse. We essentially created addicts and then weaned them down because pain was their fifth vital sign in that very extreme situation. If you're burned on 80% of your body, there's nothing we can do to get rid of that pain. Yeah. That's a controlled environment. They're in the hospital.
Jennifer, you mentioned this idea of being an addictive person. And I know Dr. Haning has said that, there's a certain way it works in each person's brain as well as every person's brain, I guess. Do you feel like that thing about being an addictive personality, do people know that? Usually, or they find out only after they become addicted?
Well, I'm an adrenaline junkie. I like to do things hard, fast, and scary. And so I think there are a lot of people that do like to do extreme sports or extreme, just seeking that adrenaline rush.
risk-taking a lot of
I
times.
think a lot of them are addicts. I'm not sure. I don't know what the statistics are, but I think that
So they're addicted to adrenaline that they get from activity, and they can
Right.
also be. Let me,
Can
doctor,
also-
let me throw out this question that came in from a viewer: are opioids more addictive than other drugs? If so, why? And if you wouldn't mind also taking on that issue about is there really a type of person who's more likely to get addicted?
So as far as the actual, I realize that there are personality types that seem to be associated with different types of drug use. Happily, I'm not sure that that you're doomed to be a drug user or a drug dependent as the result of a particular personality. If I'm going to try and answer the question about which of these is more addictive, I've got to kind of come up with some sort of definition of addiction that isn't necessarily a medical one. Because if you look at the actual impact of alcohol, for example, in this state, with a prevalence of well over 7% alcohol dependence across the state, and you look at the lethality associated with that over, say, 30 or 40 years, far outstrips anything that's going on with opioids. You could say the same
When you say
thing with-
lethality from drinking, it's the deaths from drinking-related behavior.
that
Driving
too, but
and that sort of thing, as well as, I guess, cirrhosis and other
direct
health
toxicity from the alcohol as well, susceptibility to other illnesses. If you want to be a little more direct in terms of causation, we can look at nicotine, which is as a result of its own reinforcing qualities, causes you to inhale an awful lot of toxic, carcinogenic, or lung-damaging material. Point being, do you want to say that something is more addictive because it has greater likelihood of immediate lethality? Or do you want to say it's more addictive because it's just harder to stop on a dime with it?
Well, I guess I think the way of setting you on that course is just is there a chemical process that leads to addiction, or is it a psychological process that leads to addiction?
Okay, I'm not going to be cute here, but the answer is yes. No, because these are psychosocially and physiologically determined outcomes. Okay, the whole training process, I mean, the whole business about learning how to eat with a fork is something a good deal more than just the interplay between certain transmitters inside the brain. It's also the influence of your parents telling you how to hold the thing. It's also what will materially work best to get the peas from the plate to your mouth.
Dr. Taylor, what are your thoughts about that? I mean, I think the question that we're trying to answer here is there a way of knowing whether you're more likely to get addicted from this than others? I mean, is that something people can know, or a doctor should recognize?
Yeah, definitely. I think that as we've looked at, what happens in addiction, and please correct me if I'm wrong, we begin to look at, let's say for opioids example, there's different risk tools you can look at, different factors that someone may be more susceptible to having trouble taking the medicines right, having more of an addiction type problem with it. Some people don't. Some people can take the medicines, they don't get addicted, they don't get tolerance, they can take them for pain, it works for pain, they don't have any trouble. So I think one of the things that's out there now in pain management, definitely, or pain medicine, and then looking into trying to get it into some of the other specialties is how do you identify that? Because people that are going to have that problem really would like to know, when they come in, or if you came in and you're getting a prescription, if the background's been done, and you can tell them, look, you have a family history of this, or you have, other things, medical conditions. You can be susceptible to that. Your brain may be susceptible to that.
Let me ask Claire Santos. You did mention that your sister had certain conditions in her life that may have contributed to this. Her being alone and in pain and so on. As an advocate for patients and a family member, how could family members help out with something like that, and sort of identifying the front end, let's be really careful with this?
And here we again come into communication and health literacy. We have a lot of patients who are very good at nodding their head and saying, yes, doctor, when they have no clue what the doctor's talking about. We know this. Family members can help to advocate for their loved one by sitting down the night before and designing questions to ask the physician the next day, looking it up on the internet so they could have some education about what to talk about with a doctor. Write the questions down and write the answers down. And whoever is prescribing for you is going to be willing to spend that time with you to fully discuss the pros and cons of the medicines. What are alternatives? What are your own preferences for pain management? Do you feel like you're a narcotic-taking person? Would you rather try acupuncture? Discuss options.
Yeah, there's a lot of people that just won't take these pills,
Yeah.
and then they're in pain. I mean, is that okay?
That's fear. It's, well, I should not diagnose fear, but it seems like it's fear and just lack of knowledge.
Let me, another question from a viewer, and Jennifer, I'm going to throw this one at you first, because are there many addicts who don't have any physical pain, but instead are trying to numb emotional pain, i.e. self-medicating? Was that part of your experience, and have you known other people who you think that that's probably what was going on?
I think that there are a lot of people that have gone through treatment that have emotional pain. And in order to, for instance, being raped as a young child, there were a lot of young women in treatment that I went to that had that issue, and they self-medicated to run away from those problems.
Well, you see trauma coming up so often and all kinds of adjustment problems later in life. Dr. Haining, in terms of key sort of factors, I mean, is there a profile that you can sort of say, this is a person that we really need to be more cautious with than another person?
At the most primitive level, it's going to be folks who have already experienced difficulty in managing other potentially habit-forming drugs, and alcohol is the most logical one. Even nicotine, for that matter, is probably a pretty sensitive indicator of somebody's susceptibility to reinforce compulsive behavior.
You know, I've had some experience interviewing recovering addicts, and it's amazing to me when you go outside of drug court or you go outside of a clinic, there's a lot of people standing out in front smoking.
Mm-hmm. Yeah.
So
And drinking coffee as well. Caffeine is a good substitute as well.
So that's interesting. And moving on a little bit now, more into the roots of these problems. Several questions from viewers questioning sort of the motivation of the medical profession. I'll go through all of them. How much is this problem about making money? That's from John in Kahaluu.
Good.
Brenda from Wahiawa, she went to the ER at a hospital and the doctor prescribed opioids but did not tell her what they were. She thinks doctors owe it to patients to know what they are taking. We talked about that a little bit. Yep. Medical professions is in a vicious cycle to avoid malpractice. They continue to prescribe for patients who need to be weaned off painkillers when other alternatives can be considered. Dr. Taylor, in particular, do you see physicians sort of too busy, too underpaid, too isolated to really deal with the complexities of this?
I think that, like I said, over time, you haven't had a lot of pain medicine specialists. Let's just take for over here. So you've had people trying to prescribe, and I think sometimes very as appropriately as they can without realizing the risk to the medicines. I don't think it becomes a time factor, most definitely. You see healthcare shifting to a socialized model, and so it doesn't value spending time with the patient, getting to know who they are, what are they doing, are they having difficulty. So there is a time factor. There's an access factor. You go to an urgent care, you're going to get medication sometimes for an acute injury quicker than if you're going to your primary who knows you, and you're not probably going to get to a pain medicine specialist right off the bat if you're having a problem. So yeah, I think there's a lot of factors involved.
You know, Dr. Haining, just going specifically to the money, are there physicians in your experience that basically make money off patients by giving them prescriptions for stuff they don't need?
Well, there'll be a few, and I'm not trying to minimize that, but I think we're getting off on the wrong tangent if you want to look at a genuine source for this. Yes, commercialization tends to be a major driver in terms of this process. And by commercialization, we're the only country that I know of in which advertising occurs for drugs on television. We're the only country I know of where the price index is determined by competitive desire. I won't go on a long ramp here, but I think it's kind of interesting that even now, as the screws are being turned down on the pharmaceutical industry for production of synthetic opioids, more and more brief articles are coming out about the use of opioids for things that I've never heard them being used for before. Restless leg syndrome, major depressive disorder, all of this stuff is popping up almost like the last gasps of a dying man trying to hold on to the commercial market for opioids.
You know, yeah, one of our questions in that first list was, let's look at the drug companies for a minute. And I mean, how much does the panel feel like the drug companies, in their influence on the medical profession, have had a hand in this?
Tremendous.
Go ahead.
It's another stream to the river. And as we noted earlier, the TV commercials for opioid problem centers on constipation and a drug to treat that, which brings more money to the pharmas.
A drug to treat your problem with this other drug as opposed to get off the first drug.
They're not doing patient education and how to talk to your doctor about taking pain pills. They're going to treat the side effects.
Jennifer, let me ask you, when you were fully addicted, were you just able to get all you needed from your own doctor, or did you go outside the channel? Did you actually cheat to get more of the drug?
I don't know about cheating, but I did work the system. I did have multiple doctors prescribing medications for me.
How'd that work?
Well, you would go to one doctor and you would have them prescribe for, the back pain, and then you'd go to another one and you'd have them prescribe for a psychiatrist. You could get Valium or just doctor shop. And while you're waiting in your waiting rooms where you would wait for the doctors to come out and take you into the patient room, you've got 10 other addicts sitting there, and you all sit around and talk, and you find out which ones and which doctors will prescribe. And lots of times you would go in with a doctor and it would take 5 minutes, and there was no getting to know who I was, what I was using the drugs for. It was just a quick 10-minute prescription and you're out the door.
Dr. Haney, when you hear that, I know you're not surprised by that, but what's going on there? I mean, why wouldn't? Is it just basically it's easy to fool a doctor, or is it that the doctors just don't have time to really analyze this?
They're meeting a market need. It's essentially what you were saying earlier about there isn't a sufficiency of time to manage the pain problems adequately, or for that matter, the psychiatric problems adequately. And if what's happening is you're spending most of your time buried in the electronic medical record, or for that matter, trying to squeeze in a certain number of patients, added to the fact that each of those patients is going to fill out a patient satisfaction form that determines whether or not your reimbursement from the insurance company is this level or this level this year, then you begin to see some of the pressures being turned on. I want to just be very careful not to vilify the pharmaceutical industry too much here. I think they operate on a very simplistic model, which is where there is a demonstrated desire, they will meet the market. There's no point in my referring to that as evil. It's just fairly reflexive. But from the standpoint of responding to the consequences, they haven't been very good about that.
Okay, we reached the mid part of our show, and we got some interesting questions that we'll get to in just a moment about from sort of the other side of the coin. It'll be interesting. Tonight we're talking about prescription painkillers. We always like to hear from viewers like you, so please call, email, or tweet your questions and comments. Call us at 462-5000 from Oahu, or 800-238-4847 if you're calling from a neighbor island. So this is a question I'm talking to. Mary in Kailua Kona says, there's another side of this with people who aren't addicted or abusing opioids. It's very difficult to obtain medication from a pharmacy because they don't always stock it and don't know when they'll get more. And another one, there are some for whom the cause of their pain is an inoperable condition and they have to take pain meds. I've been on OxyContin for more than 30 years and it's given me a life I wouldn't have had otherwise. Dr. Carrie Taylor in pain management, when you hear someone say they've been on it for 30 years, is that okay?
That's okay.
Okay, and tell me about when that would be okay.
That's okay. It's okay because you have to evaluate and look at function. And like she says, you get a quality of life. There is pain, there's a pain pathway, there's a reason for pain. And so if that's been identified and someone is doing well on the medicine, they're not having any side effects, they're not having addiction problems, they're functioning every other aspect, which is what you want. You want people to live the highest quality of life that they can. The medicine overall for 30, there's quite a few people that have been on that medicine for a long time. And I'm talking just in general in pain medicine. And yes, they can continue on that as long as all their other health issues are okay, they can. And I think there's quite a few people, and what I wanted to mention as well along that lines is that I think one of the overall, addiction is a medical condition and chronic pain is a medical condition, and we haven't done very well at doing that or taking care of it. And so when somebody has been on these medicines for a long time, there's a lot of people that have been that haven't crossed over into that. And even the national pain strategies that just came out a couple months ago, when they looked at what are the statistics, they've identified that between 74 and 96% of people actually are able to take the pain medicines without becoming addicted.
Let me throw up another couple questions here because they're starting to come in fast and furious. We appreciate our viewers for contacting us. And this goes to ways people might control this, or are they controlling it? Do doctors consult with the other doctors involved in a patient's treatment? I think, Jennifer, you said that it's very easy to avoid having your doctors talk to each other. Is that right?
Well, I think that was back, I was talking to Carrie earlier, and she said that now that there is more of a structure where doctors do know what other doctors are prescribing. And I think that is one of the things that really needs to be looked at in helping people that do have an addiction problem to not be able to continue to get the medications. And there are so many ways to get off of OxyContin or the drugs. Mm-hmm. And being able and giving these people a chance to go in and to get off of the medications and manage their pain in a different way, I think that that's something that needs to be explored more when you do go into your doctors.
And in just a few minutes, we'll talk a little bit more about that, how easy it is to get off of these pills. But Dr. Haining, while we're still on this topic about controls that are now in place, Jennifer mentioned that I guess there's a database that's specific to these drugs. It's not.
Yeah. So we have, so this is an example of law of unintended consequences. The PDMP, the prescription drug monitoring programs that have popped up in a variety of different states.
And that's a state program run by the Public Safety Department, right?
In different states it's run by different agencies, but they all have pretty much the same model, which is that there is a common database to which physicians may have access upon petition, upon completion of appropriate documents. And then they get access to this, which allows them to see whether their patients are receiving controlled, scheduled addictive medications at which pharmacies.
So literally a doctor could go into a computer program, and it has the name of their patient and where they're getting other prescriptions.
And determine other prescriptions, so as not to prescribe dangerously to that patient. But when I mentioned the law of unintended consequences, what we've done with the health insurance, with HIPAA, with the Protection Act against
medical privacy,
medical privacy, is it's really trammeled or hampered the ability of the physicians to talk to one another without the patient's permission. So really the only common source of information is something like the PDMP. And that really only gives you one datum, which is what the prescription is. It doesn't really allow for consultation. Ideally, your work is largely with teams, I think, and that's very much a consultative relationship.
The other thing I think would be really helpful would be for pharmacies to be able to be interlinked somehow. So there's a red flag when an OxyContin goes out of one pharmacy, it will alert you if there's that same patient is going to another pharmacy and trying to get the same medication.
The question from a viewer, and I'm going to ask this in two ways. Maury from New Orleans. Cool. It's really late in New Orleans. Is there a legal limit to how much painkiller a doctor can prescribe? And by the same token, is there a limit to how much is it illegal to do what Jennifer described doing, going to multiple doctors trying to get multiple pills? Dr. Taylor, we want to try that first?
It is illegal.
For a doctor to overprescribe or for the patient?
It's illegal to doctor shop. And in the state, we have those laws. I believe it's a felony. As far as a physician, I'm sorry, what was the first question?
Well, is there a legal limit to how much painkiller a doctor can prescribe? I imagine to one person.
There's not, but I think you have to be in the standard of care. What is the standard of care? And that has shifted. Where the standard of care in pain medicine has shifted to lower amounts of opioids as it was when you mentioned 20 years ago when it was a fifth vital sign and there was no ceiling limit. So the standard of care has shifted. But a doctor can write a prescription.
Claire, let me ask you as an advocate for patients, is it fair, are all these restrictions good? I mean, because there are people that do need to get medications, and do you feel like criminalizing the patient for doing something like that is wrong?
Absolutely. Patient has a right to privacy and privacy within their relationship with the physician. Physicians are in do no harm mode and prescriptions get written. Finding the balance in that, the ethical balance without invading that patient's privacy is part of the problem we're having today.
Well said.
And then a question from another viewer, how does the U.S. compare to other countries regarding opioids? Doctor?
Through the roof.
Way more here?
We win the Olympic gold
number
medals
one.
and all of that. Yeah,
We beat Michael Phelps.
Not really a good thing. So,
Not really.
it's not.
And why is that? All the things we've talked about?
All the things we've talked about, but again, I think most other countries, not all by any means, but most other countries regard medical services as a utility, pretty much like your water or your gas or something. It's something people are entitled to, and then you figure out how to pay for it. This is the only place I can think of where it is seen as a competitive industry. And when you introduce a competitive element to this, it's no longer a question of where you can get the best bargain on 20 sets of athletic socks. It's,
You know, Deborah, I think this says from Einaheim, a doctor is only allowed a very brief period of time with a patient. This is due to insurance requirements that determine how many patients they see, so they just tend to write a prescription as their bedside manner.
true.
And everybody's sort of nodding, yep.
I'm private
Tell me
practice.
something new, you know?
I'm private practice. I can spend as much time.
Well, that's what I was, yeah, thanks for mentioning
reason,
that.
that's
Because
why I'm private
it's about
practice.
how much money you think you need to make. Or is it,
For myself,
yeah, I mean,
No,
you make
I-
less than another doctor would make who would just churn out
yeah,
prescriptions.
but I take care of the patient.
And the presumption too is that you're going to be, you're not just relying on insurance for reimbursement, right?
No, I am.
You are. Okay.
Yes.
Yeah, there's another model that's kind of growing out there where it's not with the insurance companies. Let me throw out another question. This kind of goes back to our original thing about how people become addicted. It says, to doctors on panel, is there any connection between marijuana use in teen years and painkiller use in adulthood? And a second question is, with children being overdiagnosed for ADHD, that's a whole other show, does this become a precursor for dependency on opioids or other drugs? And I think she's asking, you know, when someone is on a drug for, you know, on a maintenance drug.
So can I answer the ADHD drug?
Sure, go
Answer
ahead.
real fast. There's actually a protective element to having your ADHD treated early in terms of lowered risk for substance use or dependence at a later time in life. That's not necessarily the same as saying an adult who comes in and has a first-time presentation for ADHD will diminish his risk. But if you take some kid who is 8 years old and has clear ADHD and begin to treat that, and it's accurately and rigorously determined that that's what the kid has, then on a cohort comparison basis, they'll actually be at lower risk for substance use dependence.
Well, they're also being seen by a doctor through a good portion of their life.
Well, that's a really important observation. You're right. There's a relationship there. Yeah.
And then another interesting call. I'm a cancer survivor with some bad outcomes from chemo and radiation. I do have to take mild opioids, but I've never misused them. It's because of the group that misuses them that has made it more difficult for the people that legitimately are using them. I've got a couple questions like this. Is it a problem for people who really need it that now they can't get it?
Yes.
It's a significant problem.
Yes.
Sorry. Yes.
What's causing that problem? Is it this database we've been talking about? Are doctors getting afraid to prescribe, or what's?
Yes. You've got more state and federal regulations, guidelines, Drug Enforcement Agency, Narcotics Division, the Center for Disease Control, National Pain Strategies, AMA. Everybody's looking at it. So I think one of the knee-jerk reactions was, okay, we're just going to stop the availability. Pharmacies just, they might have it or they can't order it, or they don't want to give it out. They start looking at the script. They start deciding if they think it's an okay prescription or not. It's made it very difficult for my patients.
Claire, it seems like you really want to weigh in on that issue.
It's a definite problem, and some pharmacies stopped carrying because they were being robbed. There's that component as well. But physicians did become afraid. They didn't. Who wants to think the DEA is following them? Tracking their prescriptions, even though that's not what's happening. Knee-jerk fear is guiding things. We have market exploitation by the pharmas, driving the market, and now we have, DEA and other entities coming in, and we're going to watch you. You're prescribing too much, and the patient in pain gets left with nothing.
Now, in a patient in that situation, Jennifer, let me ask you: would you go trying to find something else? Because we've heard that maybe the clamp on these prescription drugs has led to people finding heroin much cheaper and using that. Did you have the experience of wanting to find something else if you couldn't get the drugs?
I went to treatment, so at that point I didn't get to that. I do have a family member who did go to that. He couldn't get the prescription medications anymore and actually did go down the road of using heroin. And I think that heroin is very readily available for folks if they can't find their prescription medications.
Last question to Dr. Henning on this particular subject is, do we see when we see a crackdown on one kind of drug, another drug take off? There's always the rumor that after Green Harvest attacked marijuana, that's what caused the meth epidemic. Is that something that is pretty apparent? Clamped out on oxycodone, now people are using heroin.
Well, I understand the concept. It's just you're taking me down a dangerous path here, because it isn't necessarily an automatic reflex that people, because they can't get marijuana, start necessarily using methamphetamine. I think there's a certain amount of truth to that. Certainly what we have seen, and it's a little easier to support in this discussion, is that as one type of opioid becomes unavailable, folks will turn to other opioids. I am old enough to recall a song lyric which ran, "If you can't be with the one you love the one you're with." And that's sort of the payoff.
Love the one. Yeah, I know that song. Okay, so let's try to move on to the idea of where do we go from here? And Jennifer, start with this. What did it take to get off of it? How hard is it to move off of this, and what kind of support did you need?
It is one of the hardest drugs to get off of, in my opinion. My treatment was, there's a new drug out called Suboxone, which blocks the opioid receptors. And when you're on that medication, you don't go through withdrawal. So my third day into treatment, I asked to be taken off of it because I did not want to have to go down this road again. And it was a very painful, very long road to get off of the pain medication. It took me a good 6 months before I couldn't sleep. I projectile vomited. It was extremely difficult to get off, and you cannot do it by yourself. It's not, for me, it was not medically possible for me to stop with the amount of medication I was taking. But there are great treatment centers out there, and there is help available. You just have to want to do it. And you can't do it for your parents. You can't do it for anyone. You have to want to do it for yourself.
Claire, in your experience, how hard is it? Can people do this alone?
In my experience, they haven't been able to. And that's, I'm sure, part of the reason these support networks and treatment networks have developed.
And then, Dr. Taylor, what's your experience with helping people get off? Once they're on it, what's the best course to get off of it?
Well, for myself, if it's an addiction medical condition, then I send to addiction specialists with support. If it's pain medicine management and they're saying, okay, I'd like to go down more, my condition is better, then we have I have a way to do it, a slow wean. You're adding in some other things. You're watching the pain pathway, the response, the person, how they're doing, the function. So, but if it's a medical condition of addiction, then addiction management, and you get them to the right resources. But one of the problems is the access to addiction treatment.
That's what I was saying, Dr. Henning. Do we have beds or space, or do we have enough resources on this issue?
There are a variety of different ways to get to recovery, and there's medication-assisted treatment, there is community-assisted recovery in the form of 12-step programs and other social groups that will, in fact, provide linked arms in getting to this. There's a mixture of those. They're going at cold turkey. If folks want to look for available sites, actually, that will take them directly to treatment centers, Substance Abuse and Mental Health Services Administration of the federal government runs a site, samhsa.gov, and there's a treatment... SAMHSA. It's SAMHSA, actually, uncomfortably.gov.
If someone Googles SAMHSA, will they?
Probably it'll correct it for them, yeah.
Oh, thank you.
And they'll come up with a treatment locator. And the treatment locator is, I won't say it's flawless, but it's very good. It lists actually every facility and most individual providers in this state. But it doesn't address the basis for your question, which is, do we have enough in the way of resources? And the short answer is no.
Why is that? Anybody want to?
This is not a clientele that advocates for itself very well. It's a shy clientele, interestingly, even though people may regard them as troublesome. They're actually pretty quiet in their own advocacy, and they're not a wealthy clientele. This is not a population that generally comes well-heeled or insured.
Well, is it, I mean, to be highly cynical about it, and I know you didn't want to be trashing this industry so much, but is there any money in getting people off of drugs compared to money to get them on them?
Not nearly as much, you're correct. And it seems to be in the pharmaceutical venue that money exists.
Jennifer, when it was time for you to get off, were you able to find resources? It sounded like you were.
I was, yes. I went to a very good treatment center, and I was able to finish that treatment, and I was able to get off of the drugs.
How long did it take?
I was at the facility for 2 months, and then I came back here, and I was at another facility for another month.
So you had to go to the
about 3
mainland,
months. I did. I went to the mainland, yes.
Oh, okay. I knew this question would come up. Is marijuana a reasonable, less dangerous substitute for opioids? Let me, Dr. Taylor?
Lucky you.
I mean, because you're in the
if you're
pain
looking at-
management business, I'm just curious.
Right.
Do you prescribe marijuana yourself?
I do not, because state and federal laws, one reason, state and federal laws differ. State law says medical marijuana is okay, federal law does not. So according to the DEA, I can't prescribe opioids if I know someone is on an illicit drug. But the other thing I would say about...
Wait, try that again.
Okay.
So if someone's using, someone's using marijuana, you can't prescribe an opioid for them?
That's correct.
Okay.
Yes.
So go ahead.
And that's a law. And the other thing with medical marijuana, I think we have medical marijuana, we have recreational marijuana, and we have a blend. So I think over time, when you start getting medical marijuana, you can truly say, okay, this is medical marijuana, it's this type, it's this strain, it works for this medical condition. We're just not there yet because we haven't been able to do the research. So they've looked at different studies, and you may know more than myself as far as the statistics, but it depends on what study you look at or what information. Some people say that no, you're going to sensitize the brain, the reward center, and so marijuana is going to sensitize to other addiction and could be other drugs. And some say no. There are some patients that, if that works for them, that's their business.
That's their business.
Yeah,
Dr. Hayden, what do you think of that? Marijuana and the role of marijuana in this, both perhaps as an alternative to pain medication, but also as an alternative to addiction. Can people jump from an opioid to marijuana and get better?
Okay, so I want to keep an open mind about it, but what you need to understand about marijuana is that it's a weed that has a psychoactive substance in it. And to quantify the actual substance, whether it's THC or whether it is the antipsychotic agent cannabidiol, is something everybody is frantically trying to do right now. But for the moment, whether or not people talk about measurable content and rating the type of marijuana, it's anything but a medication at this point. Right now, it's it's hit or miss as to how much of any of the many dozens of cannabinoids are in a given amount of cannabis herb that somebody is getting. I'm finding a roundabout way to say simply, we've got a pretty clear notion of what somebody is getting with a pharmaceutical agent. We haven't brought cannabis up to that level of scrutiny yet and that level of quality control that you can say with any reliability what, if anything, this is actually treating.
Very quickly, Jennifer, did you ever try marijuana and did you ever think, oh, maybe if I just try some marijuana, I'll feel better?
I did as a youngster, but I didn't.
Not in the course of your...
I didn't care for marijuana. No.
Okay, and then are there alternatives being developed to opioids that are working? Dr. Taylor, sorry.
Yeah, I think finally we're getting around to research that's trying to find other ways to take care of pain, looking more at the pain pathway and why people have pain and where it's coming from and your pain generators and how they can intervene without the opioids, because they've really been good medications thus far for pain. But finally we're getting there.
Claire Santos, I kind of wanted to bounce this marijuana thing off of you a little bit. You looked interested in that question and you didn't jump in. But I'm also curious as to what's working for people out there in terms of getting off of it or avoiding it?
I think it's important to remember most people aren't addicted. And it's just as important to remember addiction knows no ages. I checked with AARP and there's a spike age 59 to 64. It's, what's going on? What are you treating? Are you and your provider, your physician or nurse practitioner, whoever, are you getting together and giving you the treatment that you need?
Are there alternative medicines? A person asked, do any of the panelists have experience with amino acid therapy detox? It has over an 80% success rate.
No, I have heard of studies that did not validate that, so I'm afraid I would not be able to answer that affirmatively.
I'm not going to say that's quackery, but is there quackery out there that people come and pitch you these different things? Oh, this will fix you up. Jennifer, you're actually smiling at that.
I think there's a lot of that out there, but I would like to see alternatives to pain, management other than opioids. I'd like to see, acupuncture and massage therapy, physical therapy, but a lot of those are not covered by insurance.
And another question, and this one's specific to you, Claire. This kind of is a sum it up question, and it's difficult, I know, because it must be very difficult to look back at your sister's experience. It says, what does Claire feel could have been done to help her sister? Looking back, is there anything that would have been a one thing or two things? Or
my position that developed as a result of her situation was that physicians need better education in pain management. Physicians, prescribers, need better communication skills, in particular health literacy, so that they're communicating with the patient, meeting the patient where the patient is. As I say, there are a lot of people who just nod their head and say, yes, doctor, and go home clueless. Meet the patient where the patient is at and have your discussion at that level of understanding. I'm very into access to care and health literacy, and we need to correct problems in those areas: communication, health literacy, and access to care. And that whole collaboration. We have patient-centered medical home, and the patient is supposed to be the decision maker. I think medicine has somehow, they're calling it shared decision making now. They can't quite give it up to the patient. If the patient's the CEO of their body, they own their body, they're the CEO. Surround yourself with trusted advisors. Find a provider, a physician who will work with you on what's going on.
Jennifer, did you feel, would that have been the kind of thing that would have helped you out? I mean, what did you need at the front end to prevent this from happening?
I needed my doctor not to prescribe me opioids because of my addictive personality. I'd been through treatment before, and I had stated that before. And I don't think I was really listened to. But then on the other hand, I was in pain, and I did need the pain medicine. And it's very easy to take a pill. It's very easy to take a pill and not do. I had 4 young children. I was working full time, and it was easy for me to do.
Dr. Hayden, what do you think? Where do you think we're going with this? What do you think's ahead? I've only got about a minute or so.
Oh, no. Well, one, I know a lot of people are going to be outraged that I didn't advocate for marijuana as a safer alternative for opioids. And I don't mean to dispute what other people's individual experiences are. I think a lot of folks have gotten relief on some level. You could, on some level, achieve relief with alcohol, but the question is whether that isn't particularly dangerous. I'm afraid part of the answer is in cutting off the sources of supply to this large river right now. All of those different streams that we started talking about at the beginning, the commercial or mercantile impetus to the pharmaceutical industry, the lack of education to the physicians, the lack of available treatment facilities for the folks who end up developing dependence.
Dr. Taylor, last word, what would you want to say to our audience?
I would say that it's important to work with the physician and your providers and identify what are the medical conditions. If you're having trouble, tell somebody. You know, addiction is a medical condition.
Okay, well, thank you all very much. It's been a great panel, very interesting, and I hope we helped a lot of people. We had a lot of questions, and thank you to the viewers. Next week, Insights on PBS Hawaii begins its political coverage of election 2016 with an overview of Hawaii's political landscape and a look at the important issues facing our state. As Hawaii closes in on the primary elections, we'll talk with representatives from the local Democratic and Republican parties, as well as political observers. That's next time on Insights on PBS Hawaii. I'm Daryl Huff from Hawaii News Now. Ahui ho.